start with headache syndromes, where these syndromes can be classified into primary and secondary. Where in primary we have migraine, which is the second most common type of primary headache, tension type headaches, which is the most common type of headache, cluster headaches, which is one of the worst type of headaches and also the least common primary headache syndrome, thunderclap headache, and some more. In secondary causes of headache, we have the most common infection with meningitis, encephalitis, etc. Inflammatory diseases like scoliosis, arthritis, temporal arthritis, referred pain from orbit and temporomandibular joint, icy bleeds, raised intracranial pressure, where brain tumors are the least common type of secondary cause of headache. Medication overuse headaches, which is chronic daily headache medication overuse only. Now, there are some red flag symptoms of headaches that we'll talk about in a few seconds. But first, let's see the identification of bacterial meningitis, which is very important when a patient comes to you with headache. We look for meningism, where the signs like neck stiffness, photophobia, and Kernig sign are appreciated, and a fever, which is very consistent with meningitis. Signs of shock and rash can also be seen. When a patient comes to you with headache, general management should follow, where the objective should be to find the underlying cause of headache. For that, we have to look at the presenting features of the patient, and if it gives a history of sudden peak within 5 minutes, it is probably a subarachnoid hemorrhage. And if the course is intermittent, then it could be migraine or a persistent headache, then it could indicate some serious pathologies. Now, there could be associated symptoms of some syndromes like aura, nausea, photophobia, and phonophobia, which are classic of migraine. Weight loss, focal neurological deficits, systemic illnesses, which indicate serious pathologies. Throbbing or band-like headache, which is possible of venous thrombosis. Worsening in the morning while lying down, and is associated with vomiting, could indicate a raised ICP, where the vomiting could be projectile, just to note. Then neck stiffness, photophobia could indicate meningitis with fever and some more symptoms. Then agitation, periorbital pain, autonomic symptoms could indicate cluster headaches. In patients more than 60 years of age, scalp tenderness and jaw claudication indicate temporal arteritis classically. More about some of these diseases will be discussed in later video. Now, after for the symptoms, we have to assess the patient. First, we have to check for consciousness through the Glasgow Coma scale, followed by which neurological examination should be done, where focal deficits and brainstem signs or false localization signs should be examined. Signs of meningeal irritation should be identified. Then again, signs of cluster headache should be identified, which are agitation with epiphora, facial sweating, conjunctival injection with unilateral headache should be seen. Very important, glaucoma, which is one of the most important ophthalmic emergency, will present with orbital pain, cloudy cornea, decreased vision, conjunctival injection, and systemic upset. Temporal arteritis will present with a temporal artery enlargement and tenderness, and absent pulses. Then visual acuity defects to rule out arteritis and glaucoma again. Followed by this assessment, investigations form the next priority, where a CT should be ordered if altered consciousness and seizures or focal signs of or head trauma is present. Then a neurosurgical referral should be given if hemorrhage or mass lesions are detected. Lumbar puncture is needed if suspecting meningitis or subarachnoid hemorrhage. Then, if the patient is coming with thunderclap headache, then subarachnoid hemorrhage can be suspected, where a CT should be done within 6 hours, which is highly sensitive, and a lumbar puncture, if CT is delayed, can be done to look for xanthochromia. Then CT angiogram can be given to rule out arterial dissection. Some urgent reviews can be taken from ophthalmology for glaucoma evaluation, rheumatology if ESR is coming more than 50 per hour, and temporal arteritis is suspected. Then CSF opening pressure should also be looked at to evaluate for idiopathic intracranial hypertension. Moving on with the first disease, migraine, which is a neurovascular disease caused by neurogenic inflammation characterized by severe recurring headaches that are disabling, unilateral, pulsatile, and associated with nausea lasting for about 1 day, but a duration of 4 hours to 72 hours being the usual span. The severity increases with neck movements, and these are having a slight predisposition towards female. Second most common type of headaches. There are certain types of migraine which are a migraine with aura and without aura. Without aura being the more common one, but with aura, we have visual or sensory disturbances before headaches. Less common types include retinal migraine, where scotum or partial visual field loss or blind spots could be present. Childhood periodic syndrome, where cyclical vomiting, abdominal pain, and vertigo could be early indicators of future migraines. Complicated migraine, where the migraine presents with unusual patterns and include seizures and brain lesions. Basilar migraine, where symptoms like vertigo, double vision, speech difficulties are present with occipital headache. Hemiplegic migraine, where hemiparesis or coma could be present, and familial hemiplegic migraine is due to calcium channel defects. Ophthalmoplegic migraine, where headache is combined with temporary eye muscle paralysis, particularly involving the third cranial nerve. Vestibular migraine, characteristically presenting with vertigo, and catamenial migraine, which are linked to menstrual cycle. Then to diagnose migraine, there is simple criteria that says 4 to 72 hours of consistent headache with no reasonable other cause, and and at least two of the following features as unilateral pain, throbbing pain aggravated by movements, moderate or severe intensity, and at least one of the features of nausea and vomiting or photophobia or phonophobia could be a classic case of migraine. So after this, we look at the pathophysiology of migraine, where aura is thought to be a result from cortical spreading depression, a wave of neuronal excitation followed by inhibition. Headache is linked to extracranial vasodilation and trigeminal system activation, which will be discussed in the theories of migraine. Now, so there's some genetic predisposition for migraine, where these genes are the ones that are involved, and then hormonal influences, where estrogen containing OCPs are seen to increase the incidence of migraine. Right to left cardiac shunting, so disease with right to left cardiac shunts like beta interforaminal veil, ASD, or pulmonary arteriovenous malformations seen in Osler Weber Rondeau syndrome uh, have higher incidence towards migraine. Then other triggers like stress, menstruation, and food items could be there. Now about the theories of migraine, we have a few theories. One is vascular theory, where aura is proposed to be due to the vasoconstriction of the intracranial vessels, and the pain is due to meningeal irritation, which is caused by the extracranial vasodilation. The current most accepted theory is the neurovascular theory, where the the migraine involves trigeminal system, where trigeminal nerve activation leads to a release of CGRP and substance P that leads to neurogenic inflammation, vasodilation, and central sensitization. Serotonergic theory, which is very similar, says that there's the level of fluctuation of serotonin level causes migraine, where decreased serotonergic level leads to vasodilation and pain. So triptans, which are serotonergic agonists, are used to treat vasoconstriction and reduce neuropeptide release. Moving on to management, where the patient is graded for the disability through Migraine Disability Assessment Score or MIDAS questionnaire, where a series of questionnaires, usually filled by the patient or in an interview by the doctor, and the symptoms of the patient are graded from 1 to 4, where grade 4 forms a severe disability with a score of more than 20. A score of more than 20 also indicates as triptan or most commonly sumatriptan to be the drug of choice. And the available formulations are mouth dissolving tablets, nasal sprays, subcutaneous injections, transdermal patches as well. A score less than 20 indicating mild to moderate disability, the primary drug of choice is COX-1 inhibitor, where indomethacin is given with antacids to reduce side effects. Then COX-2 inhibitor, where etoricoxib is given. And third choice is paracetamol 1 gram with caffeine. So when the patient comes with a very severe attack of headache, sumatriptan 6 mg auto injections are available that can be taken by the patient himself, which through a subcutaneous injection formulation gives relief quite effectively. Then some long-acting formulations like frovatriptan can be used, and some fast-acting uh, drugs like rizatriptan and zolmitriptan could be used for immediate effect as well. Ergotamines are usually avoided to because of their high risk of dependence, and they can cause ulcers. Triptans are usually avoided in some situations like pregnancy, princemetal angina, and some peripheral artery diseases, basilar migraine, because of their property of causing severe vasoconstriction again. Then antiemetics can also be given because the patient is having nausea, so metoclopramide. Then prevent overuse of medication, because the overuse of headache medication can itself cause headache, which is termed as medication overuse headache, which we'll discuss in few seconds. Now, prophylaxis, which forms a major part of managing these patients, is beta blockers, but propranolol is the most preferred one, though other drugs like antidepressants, antiepileptics can also be given. Estrogen containing treatments are to be avoided by these patients because the patients who are having aura are at a slight high risk of stroke. Status migrainosus. It's a condition where the migraine attack lasts for more than 72 hours and does not respond to any of the treatments given till now. So, prochlorperazine is the drug of choice, and IV fluids should be given, preferred 10% dextrose, to get over the symptoms of dehydration. Moving on to tension type headaches, where the most common type of headache is tension type of headaches. Actually, the pathophysiology of it is not very understood, but anxiety. It's a very interesting fact that anxiety about the headache itself can lead to tension type of headache. So these patients, while managing, are to be counseled to maintain stress, and actually physiotherapy to cause muscle relaxation can also help them. Clinical features like the patient might say that they're feeling a band around their head, or the pressure at the vertex with constant and generalized, which is constant and generalized, but often radiates towards the occipital region. Then it could be episodic or persistent, but there's no associated vomiting or photophobia. It is rarely disabling, and it can progress throughout the day. Tenderness over the skull is present, but can be easily distinguishable from trigeminal neuralgia, where the pain is triggered by touch, eating, or wind itself. And the exquisite tenderness of the temporal arteritis, which is very severe. Then analgesics can be taken, but chronic use of analgesics can itself cause medication overuse headaches, as mentioned. So move on to cluster headaches, which is a very severe type of headache, and talking more about it, it has slight predominance towards males, and it is associated with smoking and alcohol use. Uh, it involves the hypothalamic dysfunction and is classified under trigeminal autonomic cephalgias. This headache is when a patient complains, they say that's a very severe unilateral periorbital pain, so much so that they are actually wanting to poke their eye itself, and the agitation is so much that it can even lead to self mutilation. So, other symptoms included with the pain are epiphora, nasal congestion, conjunctival redness. The pain is so that the patient actually wakes up from mid sleep, and these headaches are usually called alarm clock headaches. Why? Because they happen at the same time daily, and they're actually very persistent to through like 10 weeks every year. Daily, the patient will be having the headaches at the same time. So management, of course, if pain is so much, would include acute pain relief with subcutaneous sumatriptan, 100% oxygen. Prophylaxis would include verapamil, sodium valproate, short course glucocorticoids, and very important non-invasive vagal nerve stimulation. In severe cases, lithium can also be considered, but it requires very strict monitoring. Medication overuse, headaches. As the name suggests itself, these headaches are a product of overuse of headache medication, where the management would include withdrawal of the overused medication. This can lead to initial worsening of the headaches, but prophylactic migraine therapy may help. And these patients will have a high relapse rate, no what. But that's where patient education and support becomes essential. Moving on, we have trigeminal neuralgia, which is again unilateral lancinating facial pain. It usually occurs in the V2 and V3 territory, as marked here. It's most common in individuals over 50 years. Pathophysiology, the cause is mostly idiopathic, but the possible cause could be vascular compression, benign lesions, or MS-related brainstem demyelination. Clinical features could include pain which is very severe and last for seconds or less, but triggered by touch, wind, or eating. There are no physical signs apart from facial grimacing. But these pain tends to relapse and remit on the management. First line is carbamazepines, where the low dose is started, which is gradually increased. Alternatives are oxcarbazepine, gabapentin, pregabalin, amitriptyline, two corticoids, and surgical options like microvascular decompression, which has a very high 90% success rate, and peripheral nerve injections of alcohol and phenol in case required. So that sums up of our topic today, and feel free to ask doubts. Thanks for watching.